everyone, hope you are all doing good. In this video, we are going to discuss about the various benign ovarian conditions. Okay, so benign ovarian tumors especially. Okay, so there are so many benign ovarian tumors which can be non-neoplastic or a germinal inclusion cyst or a pregnancy luteoma, neoplastic tumors that are derived from coelomic epithelium, cystic tumors, serous cystoma, mucinous cystoma, or any mixed forms of these also, or it can be a fibroma or adenofibroma, Brenner tumor, tumors that are derived from germ cells, and finally dermoid cyst, which is also known as benign cystic teratoma, only the benign condition, right? Okay, so these are some of the benign ovarian tumors which can be non-neoplastic tumors, Okay, so that will include germinal inclusion cyst, pregnancy luteoma, neoplastic tumors that are derived from the coelomic epithelium, then the cystic tumors, serous cystadenoma, mucinous cystoma, serous cystoma and mucinous cystoma. Cystadenoma means it will be malignant, okay. Then fibroma, adenofibroma, Brenner tumor as well as the dermoid tumor, right. Now, let's discuss about the functional cyst. So, functional cyst, this is the most common type of ovarian cyst. There are different types, okay, of functional cyst, say follicular cyst, corpus luteum cyst, and next one is theca lutein cyst, okay. So, the characteristics of this cyst include, these are usually bilateral tumors that will be less than or equal to 8 centimeter, that is they won't be more than 8 centimeters, and the size usually does not increase, okay, size does not increase. And fourth one, it mostly goes for a spontaneous regression also. Clear? So, that is what you have to know. Clear? Yes. Now, why these cysts are formed means the cyclical ovarian response in a female is continuously anyhow going to produce more follicles and they will be going for regression. This is a continuously happening in a female, okay. So, these cysts are nothing but which has occurred due to exaggerated physiological response of the ovary, okay. Yes. Now, let us discuss about follicular cyst. Follicular cysts are the most common type of functional cyst. If ovulation does not occur, then this will appear as a clear cyst that is filled with fluid and lined by granulosa cells, okay. And this cyst can be single or multiple, as well as this can be present in one or both ovaries. So, these cysts can reach up to 10 centimeter in diameter. At USG picture will be showing a completely rounded anechoic lesions which are having regular and thin walls, okay. If they are asymptomatic, then you have to just follow up. But if there is persistent increase in size, or if the patient is symptomatic, first you can offer them a medical management using combined oral contraceptive pills, or otherwise you can directly offer them a laparoscopic removal. Okay, nowadays the role of combined oral contraceptive pills in the management of functional cyst is challenged. Okay, so that's why if the symptom is more or there is a persistent increase, you can offer them a laparoscopic removal. Clear? Right. Next one, let's discuss about corpus luteum cyst. Okay. So, corpus luteum cyst is formed due to hemorrhage in the corpus luteum. Okay. So, in these cysts, there can be associated pain when there is excessive bleeding in the cyst, and because of this excessive bleeding, what can happen? This bleeding is happening inside the cyst. So, it can go for a, yes, very good, it can go for a rupture. Okay. So, this rupture can then lead to profuse intraperitoneal hemorrhage also, and when this happens, definitely there will be a need of surgical intervention. Right? Yes. Ultrasonographic picture is variable and it can be echogenic, okay, immediately when you see, okay, that is immediately after the intracystic hemorrhage. If you see, it will be showing a ring of fire appearance, and they will show peripheral vascularity, as well as this cyst also goes for spontaneous regression. Clear? Yes. So, this is a corpus luteum cyst, which is nothing but the right hemorrhagic cyst. Okay. They have shown a right hemorrhagic cyst here. Okay. So, we have seen the uterus is here. Okay. And this is the right ovary. In the ovary, there is a big cyst which is seen somewhat brown or dark in color, right? So, because of the hemorrhage that has happened inside the cyst. Okay. Right. The next one is theca lutein cyst. And the next one is theca lutein cyst. Theca lutein cysts are rare and they usually result from the stimulation of the ovary by human chorionic gonadotropin. Okay, that is, whenever there is excessive human chorionic gonadotropin, theca lutein cyst may occur. Example, yes, we have seen it in gestational trophoblastic disease. This can also happen in case of multiple pregnancy. Yes, there also HCG is more, and also in ovarian hyperstimulation syndrome. Okay, and then these cysts are usually large sized cysts, and in the USG the cysts are usually multiloculated. Okay, and the gross picture of the cyst, okay, see, this is the gross picture of the cyst. So, this is smooth, yellow, and you see so many lobules here, right? So, it is lobulated and the walls are very thin. Can you see? Yes. So, these are thin walled cyst. Okay, smooth, yellow, lobulated and thin walled cyst. Okay. So, this is the USG picture where you see it is a multiloculated cyst. Okay. So, usually most of the theca lutein cysts are asymptomatic, and so spontaneous regression will happen, but sometimes it can undergo torsion. Okay. If it undergoes torsion, then surgery can be necessary. Clear? Next one is luteoma of pregnancy. Okay, let's see what is luteoma of pregnancy. So, luteoma of pregnancy is a thing that is originating from the ovary during pregnancy. Okay, so this is usually a large solid mass, but it is usually not a neoplastic mass. Okay, it is a non-neoplastic mass, and this is usually discovered during cesarean section or in the last 2 months of pregnancy. Okay. So, cell of origin of this tumor is not established, and this usually regresses after delivery. Okay. However, if you find this luteoma of pregnancy, surgical excision is not necessary, right? Yes. And next one is, let's discuss about some of the benign ovarian neoplasms. Okay. So, benign ovarian neoplasms. See, the ovary is composing of tissues that are derived from the coelomic epithelium, germ cells and mesenchyme. Okay. So, any of the component can turn into neoplasm. So, the important types of benign tumors of the ovary include serous cystadenoma, mucinous cystadenoma and the cystic teratoma. Okay, let's discuss one by one. First, I am going to discuss about serous cystadenoma. So, serous cystadenoma, this is the most common benign ovarian neoplasm. Okay, most common benign ovarian neoplasm, and this tumor is bilateral in 20% of cases. The size is usually moderate, and if you see a gross picture, so this is a gross picture of serous cystadenoma, you will see this tumor as a smooth, okay, tumor, that is, has a smooth surface. Then papillary projections can be there, and this tumor can be unilocular or multilocular, and it is cystic in consistency. You are able to see it is cyst-like, and the content here is serous fluid. Okay. So, these are the features of a benign condition, that is serous cystadenoma. Okay. Suppose if you are seeing any solid components, or there are any solid nodules or areas of necrosis, okay, then it should raise suspicion for your carcinoma, that is serous cystadenocarcinoma. Clear? Right. Now, on microscopic examination, how this tumor will be. Okay. So, on microscopic examination, repeating. So, let us see the microscopic examination of this tumor. On microscopic examination, you will be able to see epithelium, that is especially a low columnar epithelium that is lining the cyst, and you will be able to see psammoma bodies. Okay, it is psammoma bodies that are areas of calcified granulation, right? They are areas of calcified granulation, which are the end product of degeneration and the papillary implants that can be seen, and these tumors are usually asymptomatic and they are discovered only during a routine pelvic examination or a routine imaging or a imaging that is done for other conditions. Okay. So, the chance of conversion of these tumors into malignancy is about 25%. Clear? Now, let us see the next one, that is mucinous cystadenoma. Okay. So, it is mucinous cystadenoma. So, mucinous cystadenoma is the second most common malignant tumor. Okay. This is bilateral in 10 to 15% of the cases, and there are these tumors are usually discovered at a very larger size, and they have been discovered about tumors which have weighed up to 100 kgs also. Okay. So, on gross picture, this is how it is seen. So, on gross appearance, the masses are usually round or ovoid, that is surrounded by smooth capsules. I hope you are able to see the smooth capsules here. Okay, they are surrounded by smooth capsules that are usually translucent or bluish in color. Then on cut section, you will be able to see a numerous septa that is intervening. You are able to see, right? So, there are numerous septa that is intervening, and it contains some glistening thing is there, right? So, this is a clear viscid fluid that is seen on cut section. Okay. So, you will be able to see on cut section numerous septa and clear viscid fluid. Okay. Papillae in this tumor is rare. Okay. And this is the microscopic examination picture of a mucinous cystadenoma, where you are able to see the lining, okay, of the multilocular cyst by a tall and pale secretory type of epithelium. Okay, secretory type of epithelium, and they contain mucin in the lumen, and this mucin secreting columnar epithelium is interspersed with goblet cells. These are the various fibrovascular septa that is coming in between. Okay. So, this secretory epithelium is going to produce mucin, and apart from this mucin secreting cells, you also have goblet cells, and finally you have a fibrovascular septa also. Clear? So, yes. So, goblet cells or mucin rich, and yes. Now, chance of malignancy in this tumor is about 5 to 10%. Some also believe that this tumor arises from the simple metaplasia of germinal epithelium. Okay, simple metaplasia of germinal epithelium. Clear? Right. Next tumor we are going to discuss is the dermoid cyst. Okay. So, dermoid cyst, dermoid means it has the presence of dermal elements. Okay. And remember, this is the most common variety of germ cell tumor, which will be about 95% of the cases of germ cell tumor, and among this 60% of them are benign conditions, whereas 10 to 20% of them are neoplasms. Okay. And the size of this tumor can vary between mild to moderate, and this tumor is bilateral in 15 to 25% of the cases. And one important point is these tumors are mostly seen in young women. Okay. On gross appearance of this tumor, this has a thicker, opaque and somewhat whitish wall. Okay, and on cut section you will be able to see the entire tumor is a unilocular one. Okay, and you will be able to see Rokitansky protuberance. Okay, so Rokitansky protuberance means a localized growth. Okay, this is a localized growth which will be protruding, okay, into the cystic cavity. Okay, which will be protruding into the cystic cavity. Okay, and if you check this cavity, this is of interest. Okay, so the cavity contains hair, bone or cartilage. Okay, even sometimes thyroid tissue can also be present, and a large amount of greasy fluid as well. Okay, so this is how the gross picture of a dermoid cyst will be there. Okay, so yeah, it will have any type of dermal element. Okay, so you are able to see teeth here, hair here, and yeah, what not will not be seen in this one. Okay, all the dermal elements will be seen, including thyroid tissue. So if the thyroid tissue in this benign ovarian neoplasm, that is dermoid cyst, is functioning, means it will be leading to a condition called struma ovary. Clear? Yes. Now let's see the microscopic appearance of this tumor. So on microscopic appearance, repeating, on microscopic appearance, you will be able to see all the mature ectoderm, endoderm or even the mesodermal components. Okay, so you may have stratified squamous epithelium, hair follicles, sebaceous and sweat glands, cartilages, bones or even neural respiratory elements also. Okay, that are normally seen in the early fetal life. Okay, that will be seen in this tumor. Okay, and usually the Rokitansky protuberance. Okay, so the Rokitansky protuberance is covered with squamous keratinized epithelium, and this consists of sweat and sebaceous glands. Okay, so the malignancy chance in a dermoid tumor is around 1 to 3%, and the complications that are seen with this tumor include mostly torsion, because there is a long pedicle seen with this tumor. Okay, so how you will be going for diagnosis of a dermoid cyst means, usually there are no specific signs and symptoms that can be made in an ultrasonogram, but when you do an X-ray, it will show the bone, teeth, cartilage components like that. Okay, then Rokitansky protuberance can also be seen. I am writing it short. Rokitansky protuberance can also be seen as a hyperechoic area. Okay, so what will you do for treating this tumor? Yes, definitely we have to offer them ovarian cystectomy. Okay, or you can even offer them ovariotomy. Okay, ovariotomy that can be done by a laparoscopy or a laparotomy. Okay, so ovarian cystectomy means just removing the cyst alone, whereas ovariotomy means removing the that side ovary completely. Okay, wherever the cyst is present, we are going to remove it completely. Clear? Yes. And next one, you have to keep an important point during surgery, that care should be taken not to spill the components, because the components, when it is falling inside the peritoneum, it can cause peritonitis, which will be a chemical peritonitis. Okay? Yes. Now, let's discuss about some of the solid tumors of ovary. We have so far discussing the cystic tumors of ovary, serous cystadenoma, mucinous cystadenoma, dermoid cyst, like that. Now, let's discuss about fibroma. Fibroma is a firm tumor that will be resembling somewhat like a myoma. Okay? On cut section, you will be able to see homogeneous grayish, white and firm appearance. Okay? And remember, cystic degeneration is possible in these tumors if the size is very big. Okay? And yeah, let's see about the gross appearance. So, this is a gross appearance of fibroma, which is somewhat firm in appearance like a fibroid tumor, and you have a cystic degeneration in a bigger fibroma. Okay? And when you see the microscopic examination, it will be showing numerous spindle shaped cells or stellate cells that are arranged in a fusiform fashion. Okay? So, these are numerous, you are able to see, right? So, spindle shaped cells or a stellate cells that are arranged in a fusiform fashion. Let's discuss about, see, there is a syndrome called Meigs syndrome, which is associated with fibroma, where the components will include ascites, hydrothorax and ovarian tumor. Okay, and the most common ovarian tumor will be, yes, fibroma, and other tumors like Brenner tumor or Krukenberg tumor can also be seen. Clear? Right. Now, let's discuss about Thecoma. Okay. So, Thecoma is a tumor that is usually associated with endometrial hyperplasia. Okay. So, these are benign ovarian tumors of the sex cord or stromal origin. Okay. And this accounts for 0.5 to 1% of all the ovarian tumors, and it secretes hormones. That's why these are also described as functional ovarian tumors. Okay, and it is most commonly seen in the postmenopausal age group that will be presenting as a pelvic mass or vaginal bleeding. Clear? Yes. Now, this is a picture of Thecoma you are seeing. Okay. Now, let's discuss about the next tumor, which is Brenner tumor. Okay. So, Brenner tumor is an uncommon type of ovarian neoplasm, and on gross appearance, this is seen as a well circumscribed mass. Okay, this is a well circumscribed mass with tan to yellow color, and this is usually unilateral and small sized tumors. Okay. So, on cut section also it will be slightly yellowish and somewhat bosselated appearance of the tumor is also noted. Clear? And then if you see the histopathological examination of this tumor, you will be able to see like this. Okay, there will be islands of epithelial nests or epithelioid cells. Okay, right. So, This is managed by simple excision. Okay. Now let us discuss about the complications of the ovarian tumors in general. So complications of ovarian tumors will include torsion of ovarian cyst. Okay. So this is the most common complication that is seen in about 10 to 15%. Okay, most common complication, and it depends upon the size of the tumor as well as the presence of pedicle. Okay, and usually the torsion will be happening mostly on the right side. Okay, mostly on the right side. Okay. So what happens means there is a twisting of the pedicle. Okay, so there is twisting up of the pedicle, and this usually happens with a single turn, but two or more than two turns also seen. So because of this twist, the cyst becomes congested and edematous, and when it is twisting on itself, there will be ovarian arterial occlusion, right? Ovarian arterial occlusion. So that will be resulting in gangrenous necrosis of the cyst, and infection may supervene on this. Okay. So clinically, the cyst can present as a acute or subacute pain condition. Okay, the torsion, if it happens in the cyst, means it can present as acute or a subacute condition. And in acute variety, this can be also associated with vomiting, or there can be fever, even tachycardia, and there can be other signs of shock as well. Okay. On abdominal examination, you will be able to see there will be abdominal tenderness with godding. Okay, and a well-defined lump can also be felt. Okay, whereas in subacute variety, there will be repeated attacks of pain with intermittent period of relief as well. Okay, so there will be intermittent periods of pain, because there will be untwisting also happening in this condition. Okay, so you have to do sonography where you will be seeing multiple inner concentric hypoechoic rings, okay, which is a feature of twisted pedicle, and there will be disruption of the blood supply on Doppler, color Doppler. Sometimes CT and MRI may also be useful. Okay, so this is all about torsion and how they will present. Clear? And the next one is, yes, the cyst can go for rupture, or there can be intracystic hemorrhage. There can be infection of the cyst as well. Infection of the ovarian cyst can happen from infected appendix or an infected bowel. Okay, and most commonly this happens in puparium and also following torsion. Okay, so infection usually presents with pain, abdomen. There will be definitely increase in the temperature, abdominal tenderness and rigidity will also be present. There will be high leukocytosis. So you have to give antibiotics, analgesics, and do a laparotomy after localization of the sepsis. Clear? Right. The other complications include adhesions. So, the adhesions can happen with the bowel or omentum or the broad ligament. Okay. It can be encountered during laparotomy also. And yeah, definitely there is a chance of malignant transformation as well. There can be pseudomyxoma, peritonite, and yes, that's it. Okay. Now, let us discuss how we are going to manage this condition. Okay. So, management, definitely you have to offer them surgical removal. Okay. Surgical removal, and depending upon the type and bilaterality of the tumor and the patient's profile, which will include the age, okay, her parity, future desire for pregnancy, okay, and all, you can offer them various options like it can be only cystectomy, or second option can be oophorectomy or salpingo-oophorectomy, that is removal of the ovary or removal of the tubes along with the ovary, and you can even offer them total abdominal hysterectomy with bilateral salpingo-oophorectomy. Okay. And most commonly, all these procedures will be done by a laparotomy route. Okay. So, let us see what is ovarian cystectomy now. Okay. So, ovarian cystectomy is nothing but enucleation of the ovarian cyst. Okay. And this is usually done in a young woman who is desirous of fertility and has an unilateral benign cyst only. Okay. Say it can be a serous cystadenoma, mucinous cystadenoma, or a dermoid cyst. Okay. And the second option is, yes, oophorectomy. Oophorectomy or salpingo-oophorectomy. So, here we are going to remove, okay, remove the tumor and ovary in case of oophorectomy, or along with tubes in case of salpingo-oophorectomy. Okay. So, this usually is done in a large ovarian tumor and when it is having ovarian torsion. Okay. Total abdominal hysterectomy with the bilateral salpingo-oophorectomy is done when the woman is of the peri or post menopausal age group. Okay. And there is suspicion of malignancy in this condition. Clear? Right. Now, here I am going to discuss something about the differential diagnosis of the adnexal masses, that can be either cystic adnexal mass or a solid adnexal mass. So, usually the organs which we will be considering include the ovary, fallopian tube, uterus, bowel, and other miscellaneous structures as well. Okay. First, let us see the cystic conditions, then I will explain you about the solid conditions. Okay. So, benign cystic conditions will include a functional cyst, okay, or a neoplastic cyst, and this may even include your endometriosis. Okay. And in the fallopian tube, there is chance of tubo-ovarian abscess or a hydrosalpinx, or between ovary and fallopian tube, you can also have a para-ovarian cyst. Okay. You can also have a para-ovarian cyst. And in the uterus, if it is a cystic pregnancy, you can even think about an intrauterine pregnancy that is seen in a bicornuate uterus. And bowel means it will be usually the sigmoid colon or the cecum that is distended with gas or feces. Okay. And other miscellaneous cystic components will include your distended bladder, pelvic kidney, or an urachal cyst. Clear? Now let us see the solid conditions for differential diagnosis of an adnexal mass. So, any ovarian neoplasms, okay, and here the same tubo-ovarian abscess, yes, it can present as a solid mass, or it can be an ectopic as well, or any neoplasm as well, okay. Then in the uterus, it can be a pedunculated leiomyoma, okay, and in the bowel, it can be a diverticulitis, and finally, miscellaneous causes of solid differential diagnosis of adnexal mass can include your ileitis, appendicitis, okay, your colonic cancer, okay, colonic cancer, then abdominal wall hematoma or abscess, and then retroperitoneal neoplasms as well. Clear? So, yes. So, with this, we are completing the topic on benign ovarian conditions. So, until we meet in the next video, keep going, happy learning, take care and bye-bye.